All right, good morning. We'll go ahead and get started. So for those who may not know me, I'm Dr. Karen Smith, and I have the honor to serve as the president of medical staff. And on behalf of the medical staff, I want to wish all the physicians here happy Doctor's Day. Yay! And those who may have come in, and we're going to try to show it later, thank you, nursing. How amazing you all are. They have a beautiful slideshow with a lot of great comments. And so we're going to try to get on the internet, and then we'll have it at the happy hour, the celebration next week as well, so you can really see all the things that they put out. But for those that are very particular, Doctor's Day is truly tomorrow. But here at Children's National, we always celebrate on the Wednesday in honor of John Cockherham, who is one of our amazing providers and previous president of the medical staff. And for those that complain that Doctor's Day is only one day, we have met your concerns. We're going to spread it out now for a week. And so next week on Wednesday, don't come tonight, but next week Wednesday, we're going to have a celebration at Busboy and Poets just down the road on Michigan Avenue. And so the medical staff will be buying appetizers, non-alcoholic drinks, whatever. Please come. I think the longer I've been here and being on promotions committee and meeting people, it's truly amazing the tremendous doctors we have here in this institution. And I think we often don't appreciate people that you're walking next to in the cafeteria are nationally, internationally renowned people for doing amazing things. And so I think in this urban setting, we often don't get a chance to really interact as well as we would maybe in a smaller community setting. So please come out and get to know more of your colleagues. So John Cockerham, the annual Doctor's Day Lectureship. So many people may be new here and haven't met or didn't know John. John was an amazing individual. The man had drive more than you could imagine and interests that spread beyond just being a great cardiologist. He was one of the first people really involved in informatics and how can we use technology to help improve patient care. He was our first director of clinical informatics here. To move beyond that, he actually had a love for medical staff, for policies and bylaws. And I don't know who it is, but that's a fine individual. And he would actually email me all the time about, different questions and things like that, what to do. But, we need people like that because he really just revamped the whole medical staff process, our bylaws, laid the great foundation so that we can make it through our regulatory joint commission things as stars and really setting the example for other hospitals. And beyond that, John was really concerned about how do we support medical staff members themselves. And he was one of the first people to really push through just culture. How do we determine if there's events? How do we determine what went wrong? How do we judge those? And really gave a very objective way of doing that we use now in peer review. Even moving beyond that, as he was ill and during his days as a patient, he would even still hunt me down. I'm a hospitalist, so we love family-centered care, a lot of interaction with families. And he would come and have discussions on, the value of patient-centered care and really how well can patients, even doctor patients, make decisions when they're sick. And so, again, even when he was going through his own issues, was still concerned about how do we make care better? How do we better inform our staff? And so it's really that love of medicine, that love of patients, that love of the institution and each other that we dedicate this lectureship to him. And I know he'd be thrilled that our speaker today, Dr. Hannallah, is here because he represents all those amazing qualities. He has been with children for 38 years, just retired this past December, and is Professor Emeritus of Anesthesiology at George Washington University. He was a former division chief for anesthesiology and really is a nationally, internationally recognized leader in pediatric anesthesiology and anesthesiology. In the email you saw yesterday, in 2014, the American Academy of Pediatric really gave that Lifetime Achievement Award to Dr. Hannallah for his work in pediatric anesthesiology and anesthesiology. And so it's truly amazing that he's been here with us and influencing all the trainees and staff that are here and has come back to kind of share his thoughts on Doctor's Day. I think even beyond that, where to me I think there's a lot of great people but great people that have hearts and have concern for mentorship and development of others, I think are just rise to that higher level. And just kind of hearing, all the people that know him. A year ago, Wande said, we have to have him come speak, of how many people that just love him and share how he looked after them, how he cared for them, how he passed on opportunities to him, I think really says a lot for an individual. So I hope you join me in welcoming Dr. Hannallah to our podium.
Well, good morning. Thank you, Karen, and thanks for this great introduction. It's really quite an honor to be here sharing the celebration for Doctors' Day and reflecting on not only how anesthesia started, but how we are today and how what we do can make your life easier. We should never forget, though, who we are working for. That's why I added it's all about the patient to the title there. And I borrowed that from one of our ASA, American Society of Anesthesiologists, past presidents, who said very clearly that it's all about the patient, because otherwise we have no other reason to exist. And think about that. That's why we are here, to take care of the kids and to make life easy for them. I also agree, I did know John Cockherham briefly, and he definitely was an amazing person. And this is a very good tribute to his activities here in the hospital. Now, my lecture outline is going to be to simply tell you briefly how anesthesiology started, whether it was 42 or 46, but basically go quickly to what anesthesia is today. What do we do for children, and how can you use this information to relate to your patients and your parents? I'm going to give you my take on the new FDA warning about the effect of anesthetics on the developing brain, and end up with a few minutes describing why today became Doctors' Day. Now, as some of you know, and many have guessed from my funny name and accent, I was born in Egypt, not very far from these great pyramids there. And although I've been away for almost 50 years, I still like to go and collect things that have something or meaning to do with this here. And a few years ago, I did find this picture in one of the auctions. And I liked it and bought it for two reasons. Number one, it shows how things were almost 200 years ago and before. And at that time, as you can see the pyramids in the background there, the river Nile was actually extending all the way to the base of the pyramids, which explains to some degree how they were able to get these massive stones from 500 miles away all the way to the building site. They used the river. But what I really liked about the painting is when it was actually painted, and by whom? It was painted by a British guy who was visiting Cairo at the time, and was painted in 1842, exactly 175 years ago. And if Mr. Harper at that time had fallen off a camel or something on the way in and injured his leg and had to have surgery, this would have been what he would have had to endure. There was no anesthesia. He may have been given some morphine and some maybe gin, but it was not really a very pleasant sight at all. At the same time, some 400 or 4,000 miles away in Georgia, in 1842, March 30th, there was a gentleman there by the name of Crawford Long who was experimenting with the use of ether to get his patients unconscious and pain-free during anesthesia and surgery. Now, Crawford Long was a Southern gentleman. He would do things quietly, and although he kept using ether so many times, he really never bothered writing it up until 7 years later, when he finally got it published in the Southern Medical Journal. But during that time, some more flamboyant younger dentist in Boston was able to convince a surgeon that they were going to have a very public demonstration of how ether actually works to make patients pain-free during surgery. And that became a much better known, much better publicized event, although it happened 4 years after the original use of ether. And if you want to know where the ether monument is, it's in Boston. So people remember that public demonstration more than they do the private event that actually preceded it by 4 years or so. So we're not here for a history lesson, but there's a lesson to all of us here is that if you do something, make sure you publish it, because otherwise somebody else is going to beat you to it, and they will get all the credit. So I have been doing anesthesia for some time, and I've worked a lot at the surgery center here, and I've never had any parent come and ask me, how safe is surgery? And they know the patients can bleed, they may have infection, but they know that. But many of them will come and ask, how safe is anesthesia? Is my son too young really to receive anesthesia? And I try to respond to that in at least a few ways here. Look at mortality, look at morbidity in terms of what can go wrong during and after surgery. But nowadays, if they ask, I would also discuss with them the new issue of effective anesthetics on the developing brain that the FDA is making very public these days here. So how safe is anesthesia? What are the chances of death if you have anesthesia and surgery? And 60, 70, 80 years ago, it was very high. You had a very good chance actually of dying from anesthesia independent of what the surgical procedure was. But this has dropped now over the last few years to almost nothing. If you are a healthy patient, you should not die from anesthesia. And if you look at children in particular, if you look at the pediatric age group between 5 and 14 years of age, when you are beyond the neonatal period, when you may still have some congenital issues, it's as close to zero as you can get. So in terms of mortality, anesthesia is very safe. If you look at morbidity, what can go wrong that will not kill you, it depends on how healthy or how sick you are when you come for surgery. And if you look at what we call ASA status, and I'll explain that a little bit later, but one is when you are a healthy patient, again, the odds of having a big cardiorespiratory problem is extremely, extremely low. So that is very reassuring to parents, and I think most of them are quite happy to proceed with the case. Why is anesthesia safer today than it was 50, 60 years ago? There are a bunch of reasons that you can read as much as I can here, but the most important one really is that there has been a safety culture among anesthesiologists. People believe that you should not have any bad events that can be the result of anesthesiology administration. And anesthesiologists have been known to be aware of that. In 1984, there was the APSF, the Anesthesia Patient Safety Foundation, that was established to exactly look into how to make anesthesia safer, and they were signaled out by the Institute of Medicine for building a safe patient care experience in the hospitals in general, but especially during surgery. So if you look at the individual reasons for this, better monitoring was the first thing. And as far back as 1985 and 86, the group in Boston, they had a bunch of hospitals get together and developed what was called the Harvard standards, that patients have to be monitored, that you have to have an anesthesiology provider in the room during anesthesia, something that we take for granted today, but was not always taken for granted. What became very important is that the American Society of Anesthesiologists back in '86 adopted these guidelines to become national standards, and as more and more monitors became available, the pulse oximetry, for example, they became incorporated into these standards. Entitled CO2 slowly found its way, first for intubated patients, and then eventually for even non-intubated patients. And it's funny because many of these monitors really never had controlled studies to prove their effectiveness. They just were things that happened and were used and will never ever have evidence-based reason for using them this way. The temperature control and so on. But the important thing also that has happened is that the manufacturers now are providing pediatric-sized equipment. It used to be that you just have to scramble and find anything that can work. Now we have, blood pressure cuffs of appropriate sizes. We have cannulas. We have small IVs. We have small air lines, and so on. More sensitive transducers, things that will make our practice safer. In terms of the drugs we are using, we don't use ether anymore. Most of us have not. Maybe Dr. Epstein did. And we have now sevoflurane as the main anesthetic that we use in children, which is shown here in yellow. And if you look at the hemodynamic effects, you find that it does have a better safety profile. It provides less bradycardia, induces less arrhythmias and hypotension than halothane ever did. So we do have safer drugs that we have available, we continue to use today. Our airway management also has evolved. People used to be scared of using tracheal intubation. We still use tracheal intubation, but now we have also the extralaryngeal airways, and we can do that to be able to maintain the airway without actually traumatizing the larynx with tracheal intubations. Very important is the availability of specially trained people, pediatric anesthesiologists, who are available, especially when you have high-risk patients or very small patients undergoing major procedures. And this is an issue that's a little bit controversial because many of the general anesthesiologists are resenting the fact that sometimes they are told that you really cannot do this patient, that some more specialized person should be able to do it. And just to show you the difference, most general anesthesiologists spend 3 years in training. During that time, they may have 2 or 3 months, sometimes 4, of exposure to children. And that may be the only thing they have for the rest of their life. Whereas a fellowship-trained anesthesiologist is going to have 1 or sometimes 2 years of training and get exposed to all kinds of cases there. But not every child can have a pediatric anesthesiologist. Almost 1 in 5 patients that we do in this country are children, and there'll never be enough pediatric anesthesiologists to be able to take care of these kids. So the American College of Surgeons, who are developing now this verification program that I understand we are applying to, came up with the concept of having pediatric expertise. You don't have to be a board-certified pediatric anesthesiologist, but if you can show that you have experience, and they came up with some numbers there, and where they got them from, 25 patients under 2 years of age every 2 years, but most importantly, we have ongoing experience with children. Because we all know people who have done a fellowship and then went into adult practice, and then for so many years have never seen a child. So you have to have that ongoing experience, which includes having a certain number of CME hours every year to keep that expertise and to make anesthesia safe for children. So if you are ever deciding where to send your kids for anesthesia and surgery, this is one way to ensure that they have the best possible care, especially if they are very young and for more complex surgery. Recognizes the high-risk situations. Again, that helps minimize morbidity. Sometimes these things are obvious. You have somebody who has a very small chin, has potentially difficult airway during surgery or during attempted intubation. That is somebody that should be referred to an expert who is qualified and trained to deal with these patients. Certain groups of patients, the ex-preemie, we know are at great risk for post-anesthesia apnea. They may not have huge problems during surgery, although sometimes they do, but the fear there is that if they are discharged home, they may stop breathing and then have respiratory and cardiac arrest. And it has been shown clearly that until they are 55 or 60 weeks post-conceptual age, this risk is very high, especially if they have anemia or they are extremely premature. So to make that less likely to happen, to keep them safe, there are guidelines now that are being followed that if they are under the 50 or 60 weeks post-conceptual age, they have to be watched for up to 12 hours post-operatively, so that if they stop breathing, not going to happen all the time, but if they do, they can be resuscitated and helped to breathe. And the American Academy of Pediatrics, AAP, has extended that to also include full-term babies who are under 4 weeks of age. There is no solid evidence that this is really a problem, but it's being cautious and trying to prevent things from happening before they do. And for full-term babies also, they recommend 2 hours of monitoring because some of the full-term babies, they have problems, but not for 12 hours, just for 2 hours. Do them early in the day so that you have a chance to watch them, and try to avoid using opioids that can depress ventilation. Some high-risk situations, children who have irritable airways. And very often you have a child who comes in the morning and he has a runny nose and and looks like they're very stuffed up. And these are a problem, because especially if you have that combination of having a URI and somebody who has also irritable airway like asthma, they have more chance of having a lot of secretions and having bronchospasm during surgery. Proposed surgery makes a difference. If they are coming to have ear tubes inserted for just 2-3 minutes without having to instrument the airway, they may be acceptable. And actually, there is evidence that if you do these cases and do them carefully and quickly, that you're going to cure the problem, the middle ear infection, and that they do well. If it's anything more than that, especially if you require airway manipulation, one has to discuss with the parent and the surgeon whether it's wise to proceed or wait till that clears off. Tonsillectomies. We do a lot of tonsils now. It's not anymore because of recurrent infection. Very often it's because of obstructive sleep apnea. And these patients not only don't respond well to CO2, but they also are extremely sensitive to the effect of opioids. And when I had my tonsils out many years ago, the fear there was that you can go home and bleed. That is not a problem anymore, especially if Dr. Shah is doing the case. What you worry about is they go home and they stop breathing. And actually, there are many reports now of kids who do exactly that. They have their surgery, they go home and stop breathing and become apneic and simply die. And one of the reasons for this is that if they get opioids, they are very sensitive to opioids, and especially with codeine that gets metabolized into morphine, and especially if we have somebody who is an ultra-rapid metabolizer, gets essentially an overdose of morphine, they stop breathing and die. And that's why the FDA put this warning, and most surgeons now will not use codeine for tonsillectomy patients, use non-steroidals that work very well to minimize pain, maybe not take it away completely, but also keep them safe when they are discharged. If they have severe OSA, they are not sent home. They get washed overnight, usually with a microgram. High-risk situations, and many of you use the ASA classification, and you are required to do that sometimes if you are doing sedation or requesting sedation. Just keep in mind that the ASA classification, which is 1 through 5, is not really a risk assessment tool. It's basically a way of describing the physical status of the patients. So if somebody is, and then the one level that we always argue about is 3, because if it's 2, it's mild disease, you're not really that sick. If it's 4, you are sick enough that no one's going to think about sending you home or having non-specialists do the case. But if you have the severe systemic disease, which is ASA3, the extremely, the morbidly obese patient, the end-stage renal disease, and so on, these are the patients that are high risk that should be referred to a specialist and have somebody who is familiar with children take care of them. And when I say it's not really a risk assessment tool, it's more of a physical status assessment, you can imagine that if you have somebody who is a healthy patient, ASA1, undergoing a major craniofacial procedure, that's a high-risk combination. Whereas if you have somebody who is very sick, like ASA4, having a PICC line inserted, that may not be as high risk and as much of a problem as you would imagine. So again, this is one way of maintaining safety by referring these patients to the right providers there. You probably all know, but if you don't, here you hear it. We have a POC clinic, which is, I think it's Perioperative consultation clinic or something along these lines. Dr. Karen Thompson is in charge of that, and we have a lot of other hospitalists and nurses working with her. And that's a great resource if you are in any doubt as to whether your patient qualifies to be done here or the surgery center or sent home. Just send for a POC consultation. They will call the patients, they will decide if they need to be coming here, and they will help you make that decision. So it's a very good resource, and you are encouraged to take care of that, take advantage of that. Well, children need support not only for their physical well-being, but also for their emotional well-being. And the pediatric perioperative environment is a concept that was introduced again by the American Academy of Pediatrics, the section on anesthesiology and pain management, which is, by the way, celebrating its 50th anniversary this year. So they've been around for a while, and they have had excellent recommendations and statements that were published all the time. And one of the things that they emphasize here, again, is not only that children need to be safe from physical harm, but they also need to be safe from emotional harm. And this goes back to many years ago, like 60, 70 years ago, when a study was done in Philadelphia by Dr. Jim Ickenhoff, which, again, Dr. Epstein knows very well, that shows that children who are not treated well in the hospital, sometimes patients used to be admitted for 2 or 3 nights just to have their tonsils removed. They end up having problems when they go home, having nightmares of bedwetting and doing all kinds of things that indicate that they have been harmed psychologically there. We also found that using heavy premedication, those who were heavily premeditated, had less problems than those who were not. The only problem was that heavy premedication at that time required an IM injection, which was pentobarbital, demerol, and scopolamine. And kids dreaded this deep IM injection more than they dreaded having the anesthesia induction there. Kids don't like needles, grown-ups don't care for them either anyway. So more recently, we were a part of a multi-center study looking at alternatives to this. And the alternative that is being used right now, as you all know, is oral midazolam, or oral Versed, as most of you would call it. And although it has been used for some time off-label, Charlie Cote, who at that time was in Chicago, and Ira Cohen, who was sitting right there, were able to shame the company that made it, Roche, into applying to the FDA to get approval for its use in children. And we were a part of that study. We did actually most of the cases here. And now the drug is available, is approved, and is even in a generic form right now. It works very well if it's given in the right dose at the right time, and if the kids actually are willing to drink it. Some of them, the ones that you really have the needs to have them use it, sometimes refuse to drink it. But it's a good drug. It does produce good anxiolysis and does not delay recovery if given in the right dose there. So this hospital actually has been known to not use a lot of premedication, but use emotional support of children. And I'm told that we have one of the oldest, if not the oldest, child life department in the country. It's been here for a very long time, and they have evolved and are doing a wonderful job preparing kids for surgery without having the need for all of them to be dedicated and sedated there. If you are here on a Sunday, you find that the kids are going to meet downstairs in the lobby, and they will have a pre-surgical tour. They get to go around the hospital, play with masks. Used to be a puppet show that we get to see, but now it's more electronic. We have our own show on the web, and there are available commercial sites that you can pay for, but they have more elaborate interactive educational tools for children. So to get to know what's going to happen when they come for surgery and to be prepared, assumption is that they're going to do better when they are prepared than if they are not prepared. And when we looked at this some time ago, we found that actually those who came for this tour and show, the ones in blue, were much more likely to be cooperative, even without premedication, than those who did not, which are shown in yellow. It didn't prove that the tour and the show were the reason they were cooperative. It could be because the parents were motivated enough to bring them. They were also helped in another way. But it does help, and it's very, very effective. The one thing that kids complain about all the time is being thirsty. We keep them fasting before surgery. It's a balancing act. It's a balance between safety and comfort. You don't want them to come with a full stomach, throw up, and end up with an aspiration pneumonia. But you also don't want them starving for a long time, especially more thirsty than hungry is what we complain about. Again, our society, the ASA, has come up with evidence-based guidelines for how long kids should starve before surgery, kids and adults. And they review that every 5 years and come up with either the same numbers or different numbers. And this year that was reviewed and going to be reaffirmed in October by our House of Delegates. But the numbers are the same. It's the 6-4-2 rule there. 6 hours of fasting for formula or regular milk, 4 for breast milk, and 2 for clear liquids. Not bad numbers. I think most kids probably would be happy with that. Unfortunately, when these people here did a review to see how well we follow these guidelines. It was absolutely miserable because we are not following these guidelines. We are starving our kids, either intentionally or just because of the scheduling problems for a very long time, especially kids who are being done early in the day. And this was a study done by one of our research nurses, Janet Norton, who looked at kids who were fasted for more than 10 hours, a very long time for a young child. And she found that this is more likely to happen for those who have early surgery at 7:30 in the morning than those who have late surgery after 11 o'clock. And you can see why. If you are scheduled for 7:30 in the morning, your parents are not going to wake you up at 3 to give you something to drink. They just let you sleep through and then wake up and come here. It's really a very prolonged fasting. They become dehydrated. They become extremely, extremely uncomfortable. The Europeans are a little bit more aggressive in addressing this than we are. And there are many editorials now and trials to see if you can actually cut that fasting time for clear liquids only, not for food or milk or anything else, to as little as 1 hour. And they are experimenting. This is not out in the open yet, but trying to have kids drink something before they leave home and come to the hospital. And the assumption is that it's going to take at least an hour, if not more, for them to arrive, be processed, and go for surgery, and try to see if that will help keep them comfortable and also still keep them safe. I'm not suggesting we do this here yet because that is still being simply debated over there. Well, if you don't sedate kids, and especially if you keep them thirsty, you need to keep them busy. And we have a wonderful play area, and we have things for kids to play with. We have clowns, we have all kinds of things that will keep them busy, hopefully, until the time comes for the procedure. They get to sometimes drive themselves to the operating room, and Wandy is responsible for that with, I think, board of lady visitors paid for some of these taxis. And they go to the operating room and drive themselves there. And sometimes they like it so much, they don't want to get out. And if they are otherwise healthy and they are not in danger of aspiration or anything, and as long as you have enough people standing by, I have been known to let them go to sleep in the car. They're not driving anymore, and then pick them up and have them go on the bed and continue the induction that way. We have also been known here to have the parents have family-centered care and have the parents involved in the anesthesia start in children. And when we were smaller, when we had the old operating rooms, we had almost all the parents go to the induction rooms and be with the children. And you can see how happy this kid is. He's sitting on mom's lap, he's looking at the balloon, he's having a great time. As we expanded, as ORs became so far away from the pre-op area, that is very often not very convenient and maybe not even as safe as it used to be. So we allow parents, selected parents anyway, if we had our judgment that the child will benefit from that, go with the child to the operating room, be present, and as long as there is someone available to bring them back, the children will benefit from having the parent there. And the parents very often actually enjoy that. Not only the parents, but if you have an unsterile area, this is a picture from the CMI when it's unsterile area. It's a normal location. And over there, this is Mindy. And the child is somebody who had a seizure disorder. And he always had his service dog go with him everywhere. And the dog actually would sniff the seizures before they happened. And Mindy wanted to be with him when he went to sleep. So we let her, and she gave him a hug, make sure he was safe going to sleep, and then she left. When he came back 3 years later, he was so much older, but she still wanted to be around and take care. So this work, having the parents there during induction, is a challenge, but it does help. And again, when we looked at this, the bars in yellow are when the parents were there, and the bars in blue are when they are not. We find that having an informed parent present who knows what to expect can be quite helpful during induction. If they are not informed, if they are hysterical, this sometimes can be a problem, and that should probably be avoided. Child life, again, very helpful. And Liz has been extremely helpful there when the parents are not available or not willing to be there. She would put scrubs and come with the child and play with them while they go to sleep. She has, in this case here, an iPad that has bubbles on it, and the kid is popping the bubbles as he's blowing the mask. And before he knows it, he is asleep, and you can see his arm is falling down, and she is supporting the arm up. And once she's done, she goes and leave them alone. So we do take care of the emotional needs of the children as well as trying to keep them physically safe during the surgical experience. Some kids don't like the mask. They may want to go to sleep with an IV. And we have also been a part of at least 2 trials that found that if you use EMLA or use a skin patch, you can get the skin on there. You can have a painless IV start and then continue the anesthesia this way. However, even with analgesia, many kids still just the sight of the needle get them psyched up, and they don't like to have IV starts. For that, and for the especially MRI type patients who really need an IV technique, but we need an IV to be started, what we have been doing is give a brief mask anesthetic with nitrous oxide and sevoflurane, and then start the IV, mask goes away, and continue the maintenance with propofol or something else to keep them sedated or anesthetized for the procedure. I'm not going to talk a lot about pain. That's a lecture by itself, but I'm going to mention just 2 things that are happening now just to make you aware of them. One is, I'm calling it the apology that the Joint Commission is publishing now. It came actually last week in JAMA, about how wrong they were when they started initiating the guidelines to have pain be the physical, the 5th vital sign without consulting with many of the stakeholders there. They admitted that they basically listened to a couple of very passionate people and came and required pain assessment and pain management in a very aggressive way, and you have the surveyors really be very aggressive, that resulted in unintended consequences of opioid overdosing and opioid over-prescriptions there. Now the pendulum is swinging in a very dangerous way to the other side. If you go now to New Jersey and in Pennsylvania, you cannot order opioids to your patients unless the parents sign consent. You cannot order more than 7 days worth of opioids except for cancer pain and chronic pain. And you always, of course, have to query the database about prior use of opioids there. So it's very restrictive. Somehow, somewhere, the pendulum can swing somewhere in the middle, and it becomes a more rational approach to pain management. We have here, we still use opioids. We use them in the operating room, we use them in PACU, we use them in the postoperative area. But we have a balanced approach, a multimodal approach to analgesia, and that depends on type of procedure, of course. We use a lot of acetaminophen, non-steroidals, and also a lot of regional blocks, which we have done, reintroduced actually in this country almost 40 years ago. Cardinal block is used for patients having surgery below the belly button. It's safe, it's quick, it's effective, and for more prolonged procedures, more prolonged blocks, we being the pain service, will have epidural anesthesia established there. The other problem that patients complain about all the time is being sick after surgery. Postoperative nausea and vomiting in many studies is ranked higher than pain in terms of what patients fear when they come for anesthesia and surgery. And again, we have been, I think, pioneers in doing the studies. We did not invent the drugs, but did the studies to show that ondansetron, Cockherham, is effective in a small dose to prevent postoperative nausea and vomiting. And we use a multimodal approach to this antiemetic management. If you look at the blue bars there, they are for when nothing is given. The yellows are when ondansetron, Cockherham is used. We also use dexamethasone, which is something that works extremely well for both nausea and vomiting. By itself it does, but if you combine the 2 together, you will have the least possible chance of having postoperative nausea and vomiting. And actually, I'm presenting this because I was very surprised that some of the surgical colleagues and pediatricians did not know that we are using dexamethasone during surgery almost routinely there. And they were concerned that it may affect wound healing or may raise blood sugar postoperatively. And a recent meta-analysis showed that this actually, there's no risk of increased infection, that you do raise blood sugar by about 20 mLs per deciliter or so, which in most patients is not significant, but in some patients maybe. So you need to be aware of that. But generally, a single dose given for that purpose is considered safe there. finally, I thought we were doing very well. Now we have this issue of, do our drugs cause basically learning disability and brain damage to kids when they grow up? Are we causing more children to become, Gary Larson's candidates for the school for the gifted? And the issue is, there's a lot of smoke there. Many people hear about it but don't know the details of what's going on and why this happened there. And parents will ask, although they don't always ask, but they ask. And when they ask, they need to get an honest answer and be able to make a decision based on facts there. The way this all started is the group in St. Louis, John Onley and his group, looked at patients who had fetal alcohol syndrome. And they knew that this happens when you have mothers who drink, and keep in mind, 4 drinks or more per day during the third trimester. They have babies who are born with distinct facial features and learning disabilities there. And they found, they had a nice mouse model there, that ethanol has 2 very strong properties, being a GABA agonist and NMDA receptor antagonist. And that was the reason why these patients had this low brain mass and had all these changes when they were born there. So they finished that study and they found, well, what other drugs have these same features? And they found that you have some anticonvulsants, you have some sedatives, but that all the anesthetics actually work that way. They have either one or the other. They are either GABA agonists or NMD receptor antagonists. Very few have both of them, but if you combine 2, you may have the same effect as a large dose of alcohol during pregnancy. So they went and had the same mouse model that they already had perfected and used it to test. And the reason this happens is you basically interfere with synaptic activity and signaling for the developing brain there. So they had the mouse model and did the studies and killed some mice and let the others survive and tested them after that. And there was no question, the results were very convincing, that if you give these mice a large dose of isoflurane, in this case here, and they did it for 4 hours or so, that you're going to get pathological changes in the cortex of the brain. And then if you let them survive and test them in a maze, it will take them longer to find their way around than mice that were not exposed to anesthesia. So this was published, repeated the studies with different anesthetics, created a lot of noise there. But then if you really look very carefully at what was done, yes, the results were convincing, but the dose and the duration were not really clinically relevant there. Kids are not big mice, although some of them may dress that way. There is an issue of the lifespan. The lifespan of a human is about 50 times that of a mouse. So the duration of exposure makes a huge difference. If you give anesthesia for 4 hours to a mouse, it will mean that you are giving anesthesia for several days to a baby there. And, I've never seen a surgeon who would take several days to finish a procedure. I just haven't seen it. I don't think we'll ever do. So it's not really appropriate to extrapolate the results from the mice to individuals without any thinking about the difference between them. So the way to look at this then for many people was to do epidemiological studies, look at patients who have had anesthesia and surgery and see how well they did after that. And notice I said anesthesia and surgery because very few people will have anesthesia just for the fun of it without having surgery at the same time. And there are 2 types of results that came out. And there were tens of them. I'm going to show you just 2 showing different results there. The first was the one from the Mayo Clinic in Minnesota that shows that the bottom 2 lines there is if you have somebody who did not get exposed to anesthesia or somebody who got exposed only once, there was no difference in looking at learning disability diagnosis later on. These are cohort studies. They are not looking at individual patients, just looking at how many patients had learning disabilities and how many of them had anesthesia and surgery. But what was troubling is that those who had multiple exposures, 2 or 3 or 4 times during infancy and early childhood, had more chance of having learning disabilities as they grew up. Different studies from different continents. In Denmark, they looked at kids having test scores during 9th grade. And they looked at, if you look at these bell-shaped curves there, the boys are on the left, the girls are on the right, and the ones on top had hernia repairs when they were babies, the ones in the bottom had no surgery or anesthesia at all. And I don't know if you can appreciate that or not. Of course, as we all know, girls score better than boys at that age. I think we all know that. But if you look at those who had and those who did not have anesthesia and surgery, there was absolutely no difference. So the results can be looked at both ways, and it's very difficult to interpret because there are some confounding factors there. Why would kids have 2-3 anesthetics and surgical procedures when they were younger? Many of them had hearing deficits. They had vitus media. They came for a set of tubes once, twice, 3 times. And if you cannot hear very well, you're not going to be learning very well also. Many of them had chronic adenotonsillitis, yes. And if you do that, you have this chronic intermittent hypoxemia at night. And if you are hypoxemic, you probably will not be learning as quickly and as well as somebody who does not. So that may not apply to hernia repair because hernias, unless you're doing them in an ex-preemie, there's absolutely no problem there if you have a child who's otherwise healthy. So the thing is then to do prospective studies and to try to see prospectively if anesthesia and surgery would actually affect the outcome of these babies. And these are difficult to do because, to randomize these kids and to do things prospectively requires a large number of patients and usually a multi-center approach to this. But there are at least 2 studies that were completed that showed that this is called GAS study that had babies having hernia surgery either under general anesthesia with sevoflurane or spinal anesthesia, which meant that there was no chemical feeding to the brain at all. And they saw that at least 2 years later, there was no evidence of any change in the performance of these children. The study needs to look again at what happens 5 years later, and we're going to wait to see this. There's also something called the PANDA study. We come up with these wonderful acronyms that again show that there was no statistically significant difference in performance when you look at siblings, that one had anesthesia and surgery and the other one did not. So the results were really encouraging for the last 2 years or so, and we started to become cheerful and to be able to reassure the parents that things actually are not looking as bad as we thought 10 years ago. So the FDA has been with us all the way. They have worked with the IARS, which is the Research Society, and a group called the Safe Kids, or now they call themselves the Smart Dots. And they had 3 advisory committee meetings and public hearings that did not really review all the data, did not feel there was any reason to raise the red flags and to warn the parents about any of these problems until last December when they dropped a bombshell there. With no more negative results of any studies, with all the positive results we've been having, and in spite of all that, they came up with this safety announcement that I'm putting here in bigger fonts, that if you are using general anesthesia or sedation drugs in children under 3 years of age. Why 3 years? No idea. There is a mouse study that maybe you can correlate to children, or women during 3rd trimester. Again, I don't know why. Undergoing surgery for more than 3 hours, why they chose 3 hours, or repeated use of anesthetics may affect the developing brain, and they recommended that this should be discussed with the parents and be clear to them what they are getting into. That went, of course, to the public media very quickly, and CBS News came the following day and suggested tongue-in-cheek that maybe hypnosis would be what we have to use in the future for children to avoid the use of all these drugs there. There were some very critical editorials that came out. This one came in the New England Journal of Medicine from Texas Children, the chief of anesthesiology there, and from the Mass General, one of the OB/GYN people, that basically questions the need for this kind of, the need and the timeless for this kind of advisory and implications in terms of, kids need anesthesia because they need surgery. What else can you do? Europeans were a little bit more objective about this. They looked at the fact that we may need to look at the conduct of anesthesia as well as look at the anesthetic drugs being used and spend as much money on research to do that and make it safer than looking only at drugs there. And they looked at the kind of things that we need to be looking at. They call it the 10 N's. And the first one is no fear having emotional support for the children because psychologically this can affect the way they behave and learn after that. But then the other things that we take for granted, normal tension, normocardia, the lack of changes in vital signs during anesthesia and surgery. We all know what we should do, but we don't have firm data to support our knowledge and practice there. And for example, defining what hypotension is during anesthesia, this just came out. And now that we have electronic medical records and we have a large database of numbers, we can tell what goes on there. And we found it very difficult to do that because if you're dealing with babies and small children, you really cannot sometimes get a baseline blood pressure reading. They are moving all over the place. You cannot get a baseline reading. And if you only compare what happens during the case to the beginning of the case, the results can also be very different. There were many critical reviews also, although he was talking about something a little bit different. He said that this information is really concerning to the parents, to the practitioners, but it's very good news for lawyers. Because you can imagine if mommy brings the baby for hernia repair today, and then 20 years later he doesn't get into Harvard, and she goes to TV and finds that she can go and get a free consultation, we may have a problem in the future if it gets offhand and does not get properly addressed. So when parents ask, is anesthesia safe? I don't try to be flippant, but what I have been telling them is, yes, it is. Your child is safer here, especially if they come to a children's facility with experts being there, than when you're driving them to come to the facility. And I do truly believe in that. We cannot go back to the Stone Age. Our kids are going to need to go to sleep for anesthesia and surgery, and I don't think we need to inform the parents, but not to make them alarmed, especially if we don't have the data to support that. So now that you know everything I know about pediatric anesthesiology, I'm going to spend just 2 minutes to remind you as to why tomorrow is Doctor's Day and how this gets to be associated with the first use of ether anesthesia back in Jefferson, Georgia. As probably you have heard if you were here from the beginning, March 30th, 1842 was when Crawford Long first used ether anesthesia. And this, I mean, he was a gentleman. People really had high regard for him in Georgia. But this could have been forgotten except for two very passionate ladies. Number one, his daughter, who 80 years later published a memoir in the history of biography of her father's work. And another lady who was Mrs. Brown Almond, who was, again, a Georgian, who, when she was young, admired her physician, family physician, and ended up marrying one. And then by marrying one, she became a member of the South American Association Auxiliary there. And she came up with the idea that we need to really recognize doctors. And what a better way to do this is not to use the day that the famous Georgian first used anesthesia and make that a Doctor's Day. And it is that plaque there that sits in front of the courthouse that shows that she, on March 30th, 1933, basically allowed that to be recognized. Went all the way up to the Congress twice, actually, once in 58 and then a second time in 1990, where it was signed into our bill and signed by President Bush and became the law of the land. Our society is very proud of that, and every year, this time, they come up with a poster using a doctor's care concept, not Dr. Bear, I mean, they cannot do that, so doctor's care, and they publicize the fact that this day is really associated with a big event in anesthesiology. So thank you for listening, thank you for coming, and happy Doctor's Day to all. Time for questions?
Great, we have time, yeah, for a few questions, anyone. And if not, we're waiting, but, oh, go ahead, Kathy.
Dr. Hannallah, that
yes, ma'am. Here.
Oh,
coming behind.
I can talk. People on the phone might not be able to hear me.
So first of all, I just want to say thank you to, that was a fantastic presentation and grounded in safety, and the art and the science of medicine was incredible. So thank you. And thank you to all of our physicians here. We would not be who we are at Children's National without you, without your inquiry, without your delivery of excellence and care, starting from the absolute top with our CEO, who is a physician. and we thank you for all of that. So my question for you is, tell us in your 40-some years of practicing medicine, right? Or
almost, yes.
Almost, okay. What has been your single most drive or your kind of proudest moment of being a physician, and what does that feel like?
Single moment is hard to pinpoint, but when you have a grateful parent, when you have a child who does well, and mom has a smile and a look of relief on her face when she's going home with them. I do a lot of ambulatory cases, and that gives you a chance to see and interact with the parents very quickly and very soon after surgery. When they are very tearful to start with, and then when they see the kid and everything is fine, and they go home and say thank you.
Great, yeah. Thank you. So that's, I think, why we're all here, but in particular, you just really hit the nail on the head for us, so thank you, and it was a fantastic presentation. And I will say tomorrow on Doctor's Day, this is just a little advertisement. There'll be a little cupcake for all of our physicians in the cafeteria during the day. So for those of you who aren't watching your waistline and need that extra sugar to get you through, and there'll be a little Seacrest celebration. We'll be interviewing some of our doctors throughout the day by our patients and families. So just to make it fun and light, I know you don't have time to see it on TV, but if you get a chance to stop by the Seacrest studio and participate, that would be great. So thank you.
Thank you, Kathy. So in honor, we have this beautiful little crystal plaque for you, and it's the 7th annual John T. Cockerham Doctor's Day Speaker, and it's presented in memory of the invaluable and lasting contributions of Dr. Cockerham to you.
Thank you,
so much.
I just want to add a word of thanks to Dr. Hannallah. We actually have I think three division chiefs of anesthesia here. Dr. Epstein is here, who is a chief here, and then at George Washington, and then obviously our newest chief. I worked alongside Dr. Hannallah as a fellow and then as an attending. And one of the things for the people in the audience, it's gotten to the point, and I know Dr. Miller and Hannallah believe this in their heart, but as a surgeon, and then as sometimes you just take anesthesia for granted. And if you're a pediatrician, I just want to make this point. Don't ever take that for granted. And when you get out, if you're going out into practice, the difference in the care and the outcomes of a children's hospital, don't just assume that the local community hospital or the surgery center that you might, or the urgent care, make sure you know what is going to happen with your children and families, and really think about the differentiation, because things have gotten so safe that you can get really lulled into thinking, well, that's the way it is everywhere, and it's not. And those of us in the operating room, we know if we've ever practiced in an adult or adult hospital or community hospital, there's no comparison. You don't see there what you saw here. That was the ultimate. The nursing, the child life, the preparation, the care. So just really, as you know, obviously I'm self-interested in this as being the CEO of a children's hospital, but it's different. It's really different. And if you're a parent, I know that each one of you would come to a children's hospital. So make sure that you think that through for your patients. And just the quality and the outcomes and the kind of things we can do here, whether it's cardiac surgery, whether it's procedures in radiology and GI, and to my thinking, there's nothing. You said that some things are simple, but there's no simple case when it comes to the anesthesia. There's no simple case. And the reason it feels simple is because you have experts, and they're training experts. So that's my plea here on Doctor's Day, is that we really think about our teams, we think about our children's hospitals, and we really emphasize that. We don't take that for granted. We celebrate today here at Children's our expertise, but take that with you. And when you're dealing with other parents, they'll drive hundreds of miles for a soccer game, but they might complain about going 5 extra miles to get one of the world's experts in pediatric anesthesia. Makes no sense. So take that philosophy with you if you take nothing else from this lecture today and Doctors Day. Thank you all for what you do every day. Appreciate it.